let's start. Do we want to start with answers for 13 through 15?
Yep.
Okay. Page 297. What is the purpose of CPT, Kelsey?
To provide a uniform language accurately describing the medical, surgical, and diagnostic services.
Yes. And Anita, who publishes CPT for?
AMA, American Medical Association.
Yes. Very good.
And okay.
Yep.
And CMC2, right? Category 2, no, like CMC also participate in this.
No, it's just
For national Medicare.
Yeah, that CMS is the Centers for Medicare and Medicaid Services, but the CPT is published like by the AMA.
Okay.
All right, on page 298, Kelsey, what are the 3 levels of the HCPCS codes?
I've skipped it. Level 1, 2, and 3.
Correct. I'm not going to go into each level because they are in your book on page 298 right above the question, okay?
And they're right in the summary checkpoint too.
Very good, thank you. All right, to page 302, number 2. What is the purpose of the guidelines that appear at the beginning of each main section of the CPT? Anita?
Which question?
Page 302, number 2.
It's like alphabetical appendix. For CPT, it gives it's a main code of procedural services.
We're talking about the guidelines, and what the guidelines do in the CPT book is that they help to define any terms that are necessary to correctly interpret and report the services that are contained within each section.
Yes.
So as we get into the CPT book, we will see those guideline sections and be able to utilize those further.
Mm-hmm.
All right, number 4, the 5 appendices that are contained in the CPT, A, B, C, D, and E. And those also are listed.
Page 299.
Thank you. Page 299 in your book. All right, and then number 6, what is the function of a modifier? It is a modifier provides the means to which the reporting healthcare provider can indicate that a service or procedure performed has been altered by some specific circumstance but has not changed its definition or code. All right, page 303. How is a standalone code different from an indented code? Your standalone code, you have 2 types of CPTs, standalone and indented. The standalone code is complete in and of itself. It contains the full description of the procedure without additional explanation. Some of your procedures, however, do not contain the entire written description. Your indented codes, they refer back to the common portion of the procedure listed in the preceding entry, and correct code selection will require you to pay careful attention to the punctuation in the description. So as we get into the CPT book, we will learn more about that and how they work. Page 303, number 2 on the left-hand column. What factors should be considered before assigning an indented code? Kelsey?
I don't think I chose the right answer.
Let's try.
Well, I said the number 1 to identify the procedure, service, or supply to be coded. And then it's right in this paragraph to the left that I'm looking at.
Yep.
Is that right?
Yes. Yes. Okay. Page 309. Number 2. How does an outpatient differ from an inpatient? Anitha, you want to try that one?
Yeah, outpatient means like physician's office.
Yep.
And inpatient is in hospital
Correct.
care.
Correct. All right. Number 4, Kelsey, name the 3 key components in E and M coding.
History, examination, and medical decision making.
Yes. All right. And then number 6, name the 4 contributing factors that assist the coder in assigning an E&M code. That would be that 4 of them are counseling, coordination of care, nature of presenting problem, and time. All right, page 313. Number 2, list the 2 consultation subheadings in the E&M coding. What do you have for that, Kelsey?
New or established?
It would actually be office or other outpatient consultations and inpatient consultations. And then number 4, what services are typically included in a nursing facility discharge services category? We would have a final exam, a discussion of the nursing facility stay, instructions given to relevant caregivers for continuing care, preparation of discharge records, prescriptions, referral forms as appropriate. Also on page 313, right-hand column number 2, why is it important to attach a needed modifier to a code? Kelsey?
Because some modifiers affect the reimbursement, others for documentation purposes.
Right.
Leaving it off can result in denial of payment.
Good. Yes. Turn to page 314. Number 2. What is the principal difference between 1995 and 1997 E&M documentation guidelines? The principal difference between these 2 sets of rules is the exam portion. The 1997 guidelines has a series of detailed examinations with required items indicated by shaded areas or bullets, whereas the 1995 rules have a more general counting of body areas and systems. On page 317, number 2, what do J codes represent in HCPC coding? J codes represent drugs other than chemotherapy. Number 4, explain the use of the new HCPC level 3 G codes. The answer would be beginning January 1st, 2013. The HCPC level 3 G codes are required for reporting the status of a Medicare patient's functional limitation. The G code must be used to describe the patient's functional limitations, as well as an additional modifier code to describe the full extent of the patient's specific limitations. Page 318, number 2, Which level of HCPCS codes did HIPAA eliminate? It was the level 3 codes. Page 318. Name 2 things CPT-5 is predicted to accomplish. The AMA states that CPT-5 is intended to preserve the 3 core elements that define CPT as the language to communicate clinical information for administrative and financial purposes. Ideally, it will improve existing CPT features and correct deficiencies. Any questions on 13?
No.
Anita?
No, I'll just go through like.
What?
No, I don't have anything like.
Okay.
I did.
All right. On page 326, number 2, the 4 issues that have an impact on patient expectations would be professional office setting, relevant paperwork and questions, honoring appointment times, and patient load. Number 4, what is the rationale of explaining policies and fees up front to patients? What do you think, Kelsey?
I actually don't have an answer for that one.
Well, it's simple. Today's patients want to know what is expected of them.
Okay.
Plain and simple. Up front, they want to know what is expected of them. So they want to know an approximate fee for their services, because when they go in, they have a preconceived idea of what the office visit should cost and how much their insurance should pay, but they don't know how much is expected for them, and that might be a copay or a coinsurance.
Okay.
Okay? All right, page 327. How might the internet change the future of healthcare? The internet offers access to relevant, quality health information that enables self-education and the opportunity for consumers to form their own opinions and expectations. So websites will help people to find physicians and hospitals that offer these opportunities for certain procedures, and often lifestyle advice plus educational details. Number 4, list 4 healthcare consumer imperatives that experts claim should be mandatory for patient-centered services. Some healthcare consumer imperatives are choice, control, shared medical decision-making, customer service, and information. Page 331. Number 2, list at least 6 elements that make a patient health record identifiable. Well, we have multiple, so I'm only going to list a few. All of the geographic information, all of the elements of dates, voice and fax, telephone numbers, email addresses, medical record numbers, health plan beneficiary numbers, health plan account numbers, certificate and license numbers, vehicle identifiers and serial numbers, device identifiers and serial numbers, IP address numbers and universal resource locators, biometric identifiers including fingerprints and voice prints, full face photographic images and any comparable images, any other unique identifying number, characteristic, or code. Number 4, name 3 exceptions to the confidentiality rule. What do you have for that, Anita? Anything?
Yeah, HIPAA, like, oh, yeah, like workers' compensation, like you don't have to have HIPAA.
The three exceptions would be any public health issues,
Public, yeah.
judicial and administrative proceedings, and law enforcement purposes. All right, page 335. Name 3 things that are important for patients to know about a healthcare practice. Approximately how much the medical service or procedure will cost, when they are expected to pay for the medical service or procedure, what the practice is willing to do as far as claim submission to their insurance carrier. Number 4, a computerized patient accounting system can generate many kinds of documents. Name 4, a list of patient appointments, a current copy of a patient's ledger, patient's receipts, statements, aging reports, and insurance claim forms. Page 339. Number 2, explain how an alternate billing cycle can be used. Kelsey?
Billing system that incorporates the mailing of a partial group of statements. And breakdown of accounts is frequently determined by an alphabetical list of last names or account numbers.
Yes. All right, number 4, name the 4 conditions that must be met under Regulation Z when a business extends credit. The 4 conditions are that the credit is offered to consumers, credit is offered on a regular basis, the credit is subject to a finance charge or interest must be paid in more than 4 installments according to a written agreement, and the credit is primarily for personal, family, or household purposes. All right, page 340. List the 5 federal laws that affect credit and collection. Number 2. Generally, if a state law allows more time for the debtor to notify the creditor about a billing error than the federal statute does, which prevails? Usually, if the state law conflicts with the federal statute will prevail. But there is one exception. A state law will prevail if it gives a consumer more time to notify a creditor about a billing error. All right, number 4, name the 3 telephone limitations upheld by the Fair Debt Collection Practices. Kelsey, what do you have for that one?
At any time or place that is unusual or known to be inconvenient to the consumer, when the creditor is aware that the debtor is represented by an attorney, and at work if the creditor is aware of the fact that the patient's employer prohibits them from calling.
Okay. On page 341, when should the healthcare practice make its first collection call? What do you think, Anita?
Patient, more affected patient. 5 p.m. to 8 p.m. Making collection costs for the day with special emphasis from 5 p.m. to 8 p.m.
in the
Yeah.
next.
Oh, let's see.
Is that what the question was asking? Or
When
was it
should you
4 to
make
6 months?
when should you make a first collection call? It would be approximately 15 days after a second statement has been mailed out.
Where is it? In which page?
Let me find it. Hold on. They don't tell you specifically in here.
Yeah, here, I think in 1410, we must hear from you within 15 days of date of this letter.
There you go. You got it. In the example. Perfect. All right, and then page 342. Number 2, list 5 functions of a billing service. Kelsey?
Preparing and submitting insurance claims, providing data entry of patient demographics, tracking payments, producing practice management reports, and collecting delinquent accounts.
Yes. Okay. And page 342, number 2. A collection agency is 4 reasons a healthcare practice might hire a collection agency. They're too small to have a collection department of their own. They lack the expertise to collect delinquent accounts themselves. They think a collection agency will get faster results, and they simply don't want to deal with the hassle of collecting. All right, number 4, name 3 things to look for in a reputable collection agency. Employ trained, certified collectors who understand and abide by the Fair Debt Collection Practices Act and follow the requirements of state laws. They are insured, licensed, and bonded, and they are able to collect in other states. Page 343, over on the right. What is a typical monetary threshold for a small claims suit? Monetary threshold for a small claims suit. It varies by state, usually anywhere from $3,000 to $5,000. However, there is ongoing legislation in many states to raise this limit to as high as $10,000. Number 4, list the 4 elements of information that must appear on the small claims form. The 4 elements are the name of the party being sued, the current address of that party, the amount of the plaintiff's claim, and the basis or proof of the claim. All right, that's it for 14. Any questions?
No.
Okay. All right, let's move on to 15. Page 348. Why should health insurance professionals learn how to complete the paper claims? Anita, why do you think?
Yeah, like a small physician's office, they do paper CMS 15.
Yep.
So we should be aware that we should be aware of both paper and electronic.
You should be able to do both. Absolutely. Yep, you've got it. All right, number 4, true or false? Kelsey?
Is it false?
It is false. Good job. All right, page 351. Number 2. What is the result of failing to obtain pre-authorization or pre-certification for certain procedures, such as inpatient hospitalization? Some third-party payers will reject certain types of claims if they do not know about and approve the services beforehand. All right, what is a clean claim? Anita, what is a clean claim?
Means without errors, and it is means like all of the information necessary for processing the claim has been entered on the claim form, and
Yep.
information corrected.
You got it. All right, page 352. All right, number 2, how does a provider acquire an EIN? Kelsey?
The IRS assigns it to the.
Yes, you want to submit an SS4 form. All right, page 361, number 2.
Doreen, I have a question.
Yeah.
What is the difference between CMS 1500 and UBO4?
One is for outpatient, so the CMS 1500 is for outpatient, and the UBO4 is for inpatient for hospitals. All right, number 2, if the insurer determines a claim is unclean, what happens to it, Kelsey?
It's denied or rejected.
It is. All right, the 4 common payment errors. If you look at table 15-1 in your textbook, that will give you a list of the common payment errors, and that is going to be on page 348.
I thought it was 357.
Oh yes, I got table mixed up with the figures. Sorry. All right. Page 362, number 2. What document typically must accompany a secondary claim? Kelsey?
The primary claim?
Yes, the primary claim and
EOB.
EOB. Yep. Page 363, number 2, true or false? RTCA reduces the time frame of claim submission to adjudication from 2 to 6 weeks to just a few seconds. That would be what, Kelsey?
True.
True. Sorry.
It would be true, yes. All right, number 4, what is the name of HIPAA's method for providers to receive information electronically regarding the status of claims? What would that be, Anita?
277.
I'm sorry?
Like EDI 277?
It would be a healthcare claim status inquiry or response system.
Oh yeah, that's is 277.
Yeah, well, is that what you mean?
Yeah, this is what I read somewhere. I remember.
Yes, you were on the right track.
This whole thing is like so
It's a new
much-
language, right?
So much in our brain. It's, for a first time reader, it's too much.
It is. It is. That's why the lectures are helpful. All right, page 364, number 2. If a payer does not respond to an appeal, what alternative does the health insurance professional have? Kelsey?
I think they can notify the insurance carrier.
Prepare.
They can also notify the state commissioner. And then the second option is to file a complaint with HIPAA, and then also possibly getting the patient involved.
Okay.
Okay?
Yep.
All right. And that's it for chapter 15. So we can go right on to chapter 16. We'll start on page 367.
Are these our last chapters of this book?
Yes?
Wow.
Till 18. And yeah, this is okay, I guess. 16, 17, 18. Oh, it's here. UPO 4.
Okay. All right, so let's get started with chapter 16, and this is all about the role of computers in the health insurance. So what do we use our computers for in healthcare? We
For
use them
information. Like, yeah.
on page 368 in your textbook. We use them for enrolling individuals in the health plans, helping to pay the health insurance premiums, checking eligibility, obtaining authorization to refer a patient to a specialist, processing claims, using electronic medical records, and then notifying a provider about the payment or non-payment of a claim. HIPAA's role in electronic transmissions. HIPAA's Administrative Simplification and Compliance Act, also known ASCA, requires health plans and clearinghouses to use certain standard transaction formats and code sets for the electronic transmission of health information. The ASCA requirements also apply to healthcare providers that transmit health information in electronic form in connection with the transactions covering in the rule. So the goals are to reduce the number of forms and methods of completing claims and other payment-related documents. And we want to use identifiers for healthcare providers. When we do this, it increases the use and efficiency of the computer-to-computer methods of exchanging standard healthcare information. So there are 5 areas of administrative simplification. EDI, being the first one, is the electronic transfer of information in a standard format between 2 entities and allows business entities to exchange information and transact business in a pretty rapid and cost-effective way. Second are your code sets. These include data elements that are used to document uniformly those reasons that patients are seen and the procedures or services provided to them during the healthcare encounters. Your HIPAA adopted specific code sets for diagnoses and procedures to be used in all healthcare transactions. The third one being identifiers. These are the numbers used in the administration of healthcare to distinguish individual healthcare providers, health plans, employers, and patients. These identifiers must be used in all of those transactions as required by HIPAA standards. Fourth, we have security standards. These need to be developed and adopted for all of the health plans, the clearinghouses, and providers to follow, and to be required at all stages of the transmission and storage of healthcare information to ensure the integrity and confidentiality of those records at all phases of the process. So that would be before, during, and after electronic transmission. And then lastly, privacy standards. These are intended to define the appropriate and inappropriate disclosures of individually identifiable health information and how patient rights are to be protected. So EDI offers the prospect of easy and inexpensive communication of information throughout the healthcare community. In the case of insurance claims, EDI is the electronic exchange of information between the provider's office and a third-party payer. Electronic transmission actually began during the 1960s, initially in the transportation industries, when standardization of documents became necessary. The U.S. Transportation Data Coordinating Committee, or also known as TDCC, was formed to coordinate that development of translation of rules among 4 existing sets of industry-specific standards. What are some of the benefits of EDI? Kelsey, can you name some benefits for me?
Faster transfer of data, fewer errors, instant retrieval, so less time wasted on exception handling.
Yes. Also inventory management, cash management.
Transport, distribution.
Yep. So the electronic claims process. There are 3 ways to submit claims electronically. Direct data, which is your carrier direct, your clearinghouse, and your billing service. To send claims electronically, the medical practice needs a computer, a modem, and a HIPAA-compliant software. The enrollment process. Most of your carriers require a medical practice to go through the enrollment process before the practice can submit claims electronically. This process will typically involve completing and returning EDI setup requirement forms, and some carriers require the practice to sign a contract. Your electronic claims clearinghouse, they receive claims from several medical facilities, which then consolidates the claims so that one transmission containing multiple claims can be sent to each insurance carrier. This serves as that intermediary between medical practices and insurance companies, facilitating the electronic exchange of information between the facilities. And you'll see that there's a figure or diagram in your textbook that shows the electronic claims through the clearinghouse. how it translates the data into elements that format is compatible and required so that the target insurance carrier can pick it up. Once that data is reformatted, it is then sent electronically, usually overnight, to that target insurance company for processing. The insurance company then prepares the EOB or an RA, which is sent electronically back to the clearinghouse, and then that data is reformatted and transmitted back to the originating medical facility. So you'll see on page 370 just how it gets back and forth. All right. Data claims. This is DDE claims. A print image of the insurance claim file is created. Then we use the practice direct claim software, and the claim is sent directly to the insurance carrier. And this method actually varies from carrier to carrier. Your clearinghouse versus direct, there are several things to consider there. What are those things that you would consider, Anita?
Like it's a time consuming, like a direct data entry, or you may make mistakes or errors.
Right. What are some of the expenses that involved? How many of your carriers does your practice submit to?
Yeah. It's I guess it's slow process because each claim should be entered. This is not going to be a batch process, right?
It might not be. All right. Advantages of filing claims electronically. What are some of those advantages, Kelsey?
Faster, more efficient claim submissions with fewer errors. Provide immediate notification if a claim has been accepted or rejected and why. Allow faster processing of claims. Do you want me to read them all?
Yep.
Generate electronic remittance advices from health plans and quickly and accurately post them to the accounting system of the practice automatically. Provide claim status information reports. Use a universal set of codes with all health plans. Reduce claim denials owing to eligibility. Acquire prior authorizations and referral requests. And reduce claim denials because of authorization or referral issues.
Very good. Okay, Medicare and electronics claim submissions. Department of Health and Human Services have a final rule for the electronic submission of Medicare claims, and it's mandated under the ASCA. This rule does not require any other transactions to be submitted electronically. So changes, adjustments, appeals, those do not get submitted electronically. There are exceptions to the rule. What are those exceptions to the rule, Anita?
Medicare claims and the rule. I was sorry. I was reading in the exceptions to the rule. Sorry. Exceptions like roster billing, claims for payment under Medicaid demonstration project that test and measure the effectiveness of program changes. Yep. Claims more than one plan is responsible for payment before Medicare.
Yes. Very good. All right. So what are the advantages of EFT over on page 372? What are some advantages to EFT, Kelsey?
It reduces the amount of paper, eliminates the risk of paper checks being lost or stolen in the mail, saves time and eliminates the hassle of going to the bank to deposit the checks, and speeds up funds to the provider's bank account.
Yes. Yes. All right. What about ERAs? What do ERAs do, Anitha?
Electronic remittance advice. In addition to EFT, Medicare and other carriers offer an ERA. ERA allows the provider office to receive explanation of benefits or RA electronically. With an ERA, payment can be posted automatically to patient accounts, allowing the health insurance professional to update accounts receivable much more quickly and accurately than if she or he had to post payments manually.
That's right. I can tell you from personal experience, ERAs are a godsend. Manual posting takes forever. Transitioning to ICD-10 on January 1st, 2012 on page 375. Standards for electronic healthcare transactions changed from version 4010 to version 5010. Your version 5010 accommodates the ICD-10 codes, and there are GEMS mapping involved in the transition. The electronic medical record, or EMR, is an electronic file wherein the patient's health information is stored in the computer, and this information contained in the EMRs varies greatly in type, ranging from simple and routine clinical data to sophisticated medical images. Your EMR data will include your patient's history, the transaction capability, and administrative functionality. We do have EMR hybrids on page 376. And this is a combination of records, both electronic and paper documents. Digital imaging hybrid. This is where existing paper documents are scanned and digitally filed. Then you have paper documentation that may then be disposed of or stored off-site. Potential issues, the cost of transition to an EMR, the amount of time to transfer the records, potential disruption of care, possible need for additional staff, numerous EMR systems to choose from, which might present incompatibility issues, and security. And the future of EMR. EMRs will have the potential to streamline our workflow efficiently, improving adherence to treatment standards, providing detailed financial practice analysis, enhancing patient education and interaction, and optimizing compliance with regulatory and managed care guidelines. Any questions here?
No.
No.
All right, your EMR trials and meaningful use. There is a federal incentive program which gives incentive monies, provides incentive monies for providers who are using meaningful use. And the stimulus money, there's three components of a certified EMR. Use in meaningful manner, so electronic prescriptions, use for electronic exchange of health information, and use to submit clinical quality and other measures. Your EMR incentives is projected, they're saying, to improve care coordination, reduce healthcare disparities, engage patients and other family members, improve population and public health, and also to ensure adequate privacy and security.
Doreen, what's the difference between EMR and EHR? The real difference.
At one time, there used to be a difference. Okay, EMR is the electronic medical record, and EHR is electronic health record. What they originally thought was that the electronic health record would be something that is worldwide. So no matter where you went, you would have this electronic health record. An EMR is specific to a practice. So you go to your specialist, they have an EMR, an electronic medical record specifically for you. It does not get shared with anybody. But with these big hospitals and physician practices that have this, that are utilizing the same system, that would be considered an electronic health record. So if I go to my physician's office over in Thaco and they're part of Southern Maine Healthcare, and I go to Southern Maine Healthcare for an x-ray, they should be able to access my records because my participating provider is part of Southern Maine Healthcare. Does that make sense?
Yes.
So they're actually interchangeable. At one point in time, they really were trying to keep them separate, you know. So just try to think of them in that manner, okay? So doctors who do not subscribe to an EMR over the course of the next few years will actually have their Medicare payments penalized from 1% to 3% over the next few years. So if they have a pretty high population of Medicare patients, they will end up with a pretty substantial penalization on their reimbursement. That wouldn't be fun. What do you think?
Yes, that is. And it means like in computer, do they store in different formats like EMR and EHR or same document?
Say that again?
Like EMR and EHR, the content is same.
Yes. Yes.
Do they save it in a one document or in a different document?
No, it should all be saved within the same document. Think of it like a file cabinet. All right?
And it's a file cabinet that EMR can access and EHR can access? But
Yes.
it's all in one?
Yes.
Okay.
If they have computers and the program that are talking to each other. So the best one that I can give you for an example is the Southern Maine Healthcare or Maine Medical. Okay, they are all now part of what is called Maine Health. Have you heard of it?
Yeah.
Okay. So Maine Health or Maine General is the big category in the file cabinet. Okay, so if we're setting up categories within our file cabinet, Maine Health is the head honcho. And underneath Maine Health, you have all these outpatient clinics and practitioners who are providing care as part of being Maine Health. So they are all accessing the same data and computer system. All their computers are talking to one another back to the umbrella. So if they are in South Portland or Westbrook, but they are all connected to Maine Health in Portland, they are turning on their computer and they're accessing data about you in Maine Health. So all of the systems are communicating with one another. that would be what is considered an electronic health record. So it would have the same data, the same type of forms, probably see the same x-rays and lab results and stuff like that. Now, if you went to a specialist who is not part of Maine Health, their computer system does not talk to Maine Health. You would have what's called an EMR in their practice because it is completely separate from Maine Health. The type of documentation is the same, the content is the same, but it is a totally separate system.
Availability, like.
Right, right. Now, I can tell you with this incentive program, a lot of practitioners just started what they call stage 1. And a lot of practitioners are also in stage 2. There's different stages, and depending on when the practitioner started, they're in a different stage. Stage 2 actually is working on communicating between all of those different providers, no matter what you have for an EMR. Being able to submit data from, let's see, your OBGYN over here in, South Portland to your PCP over here in Gorham. Two separate practitioners, but still having the capability to submit encrypted documentation that they can share. That is what they're working toward. So even though Maine Health has a different software and computer system, your OBGYN should be able to submit data that they can access and put into your electronic health record. Okay? Does that help?
Yes.
All right. Okay, reimbursement procedures, getting paid, Chapter 17. This is always a fun chapter. All right. So understanding reimbursement systems. There are actually 5 elements that impact the dollar amount paid. The third-party payer, the healthcare setting and provider, the coding system, which is your ICD-9 and your CPT, the data set that's used, and the encoder, grouper, and data entry software that's used. Your current reimbursement systems are based on these 5 elements, and the rules are constantly changing with the frequent introduction of new payment formulas, and it takes diligence and dedication to keep current with these changes. Small adjustments in payment rates can make a big difference in practice income. We have types of reimbursement over on page 383. We have the fee-for-service, which is a system for payment of healthcare services whereby the provider charges a specific fee for each service rendered and is paid that fee by the patient or by the patient's insurance carrier. When a healthcare provider offers services at rates that are lower than the UCR fees, that arrangement is called discounted fee for service. And then with a PPS, or prospective payment system, reimbursement is made to the healthcare provider on the basis of predetermined factors, such as the patient category or type of facility, and not on individual services. PPS is Medicare's system for reimbursing Part A inpatient hospital costs. We have relative value units, managed care organizations, and capitation. Capitation is a method of payment for our healthcare services in which the provider or healthcare facility is paid a fixed per capita amount for each individual to whom services are provided without regard to the actual number or nature of the services provided to each individual patient. This is often a common method for paying physicians who are in HMOs. The RVS or RVU consists of a relative value for physician work, a relative value for practice expense, and a relative value for malpractice risk. The RB-RVS, there's three components: total work, which is your time, technical skill, mental effort, physical effort, judgment, and stress, your practice costs, and your malpractice costs. With Medicare and reimbursement on page 385, Medicare's three primary reimbursement systems: prospective payment, fee schedules, and Medicare Advantage. Medicare's prospective payment system, or PPS. Congress has four chief objectives in creating this. The first one is to ensure fair compensation for services rendered, not to compromise access to hospital services, particularly for those who are ill. Second, to ensure that the process for updating payment rates would account for new medical technology, inflation, and other factors that affect the cost of providing care. 3, to monitor the quality of hospital services for Medicare beneficiaries. And 4, to provide a mechanism through which beneficiaries and hospitals could resolve problems with treatment. How does the PPS work? There are actually variations of payment systems. There is the acute inpatient, the outpatient, the skilled nursing facility, and the home health. CMS also develops the schedules for specific providers and services, such as your physicians, your ambulance services, your clinical laboratory services, your durable medical equipment, and supplies. Your DRGs, or your diagnosis-related groups, over on page 388. This is a grouping that is based on diagnoses, the procedure performed, the age, sex, and status at discharge. Your DRGs are what is used for reimbursement in the PPS of the Medicare and Medicaid healthcare insurance systems. So, how do they work? The principal diagnosis and the principal procedure is what determines the DRG assignment. There are other factors that affect this assignment, but they are secondary diagnoses: the patient's age, the presence or absence of complications and or comorbidities, the patient's sex, and the discharge status. All of this information together will determine the DRG category, which then sets that dollar amount for the acute inpatient hospital visit. So how do we assign a DRG? Each DRG is assigned a relative rate and an average length of stay. How do we calculate those? Well, it's multiplied by a standardized amount, which is a figure that represents the average cost per case for all Medicare cases during the year. The standardized amount is the sum of a labor component and a non-labor component, and if applicable, there's cost outliers, disproportionate share, and indirect medical payments that are added to this formula. So how do we get ambulatory payment classifications? This is a service classification system that is designed to explain the amount and type of resources used in an outpatient encounter. Each of your procedures or treatments are assigned an APC code. The services in each APC are similar clinically in the terms of the resources that they require, and there is a fixed payment rate that is then established for each APC. The RUGs, Resource Utilization Groups, over on page 390. The basic idea of RUGs
I have a question.
Sure.
How means like how do they group like these diagnostic related groups and this one?
What page?
Like DRGs and resource RUGs, do they group together? Like Medicare, these are related to Medicare, right?
They are related to Medicare, yes.
And do they group related to the diagnosis and then
Yes.
reimbursement?
Yes.
Who does that?
CMS. And then you learn how to find it in a book.
Mm-hmm.
So the basic idea of your RUGs is to calculate the payments to the skilled nursing facility. And then each patient is classified into that resource utilization group to determine the per diem payment to this skilled nursing facility. So unless you really get into doing a lot of Medicare stuff, you're not going to touch any of this.
Mm-hmm.
If this is for information to store in your brain in a drawer that you're going to access sometime later on. Medicare and the RBRVS, your Medicare RBRVS physician fee schedule replaced the Medicare physician payment system in 1992. There are actually 3 components of the relative value for a service. What are those, Kelsey?
The 3 components, you said?
Yes, please.
The amount of physician work that goes into the service, the practice expense associated with the service, and the professional liability expense to provide the service.
Yes. All right. Establishing Medicare payment policy. CMS administers and oversees the Medicare program. New advisory board was created under 2010 health reform law, and there is an independent payment advisory board that helps oversee this. Your Medicare long-term hospital, PPS, your long-term care hospitals, they treat patients who require hospital level care for an average of 25 days. This uses long-term care DRGs as the patient classification system, and you'll see that the grouping reflects resources used for treatment. There's also a significance of reimbursement systems to health insurance professionals. So to function well in our job, we need to have a working knowledge of each of the systems that we've discussed in this chapter. Also to what category of patients each one is applied, how it's structured, how the fees are established within each system, and then on what fees the system is based. Your peer review organizations and prospective payment systems on page 392. You have the peer review organizations, which are the PROs. These were established by TEFRA. TEFRA actually reviews the quality of care and appropriate of admissions. readmissions and discharges for Medicare and Medicaid patients. Our peer review, the basic responsibilities of a peer review is to ensure that Medicare hospital services are appropriate, necessary, and provided in the most cost-effective manner. Computerized patient accounting systems, the functions that they can perform, input and store patient demographic and insurance information, post transactions, allocate system control operations, generate patient statements, process and submit insurance claims, manage and collect delinquent accounts, create reports. When we are managing transactions on page 393, the typical transactions will be posting and tracking patient charges, processing payments, and making adjustments to patient accounts. When we are generating reports, we are generating, page 395, generating reports. We are patient day sheets, procedure day sheets, patient ledgers, patient statements, patient account aging, insurance claims submission aging reports, practice analysis reports. Some other reports, accounts receivable aging report. This shows how long invoices, or in this case, patient accounts, have been outstanding. Insurance claims aging report, practice analysis report. You see these right in your book, page 396, 97, 98. Okay, HIPAA and practice management software. There are two principal areas that are affected by HIPAA. It is your billing software and your practice management system. HIPAA does not require medical practices to purchase computer systems, but you must have a HIPAA compliant software system that will help reduce the administrative costs. What are some of the capabilities of the practice management systems? Well, most of them can provide various functions. Tracking date of consent to release PHI, maintaining electronic copies, tracking patient requests, tracking patient revoked consent, and tracking patient authorizations. Also, when you're contracting with a business associate, HIPAA defines a business associate as an individual or corporate person who performs on behalf of a covered entity any function or activity involving the use or disclosure of PHI. And usually it's not a member of a covered entity's workforce. Any questions on chapter 17?
No.
Anita?
I still have that, like, how do they group? It's like depend on the area, all the Medicare
Area, age, situation. Don't get stuck on it.
Yeah.
It's going to drive you crazy if you do. And because it's not part of outpatient, don't get stuck on it. What you're learning is more outpatient, okay?
Yeah.
All right, let's turn to chapter 18. We're going to just review hospital billing. Remember, I talked about how we probably won't be going into it a lot because hospital billing is not on the national exam. Okay, so we're going to just review it. So hospital billing and the UB04. So when you asked earlier the difference between CMS 1500 and UB04, It simply is the form that the hospital is using. So the difference between hospital versus physician office billing and coding. Your functions are going to be pretty similar. They have supporting administrative processes. There's billing through classification systems. There is medical education, research, data scrutiny, and release of information to authorized users. It's going to be different systems that you use, and different forms may be appropriate here, like the UB04 or the CMS 1500. The ideal modern hospital is where your sick or injured people seek and receive care. In most of the teaching hospitals, education is provided to healthcare professionals. Then you have continuing education for your practicing physicians, and you also have institutions of higher learning that conduct studies and research. We have hospital regulation. Hospital regulations. Sorry. With today's modern hospital, we have them being regulated by federal laws, state health department policies, city ordinances, and they have accrediting organizations such as the Joint Commission and national and local codes, building, fire protection, sanitation. There's many requirements to safeguard patients' privacy and safety, as well as their well-being of patients and staff. Some of the emerging issues on page 406, there are several emerging issues that affect today's hospital. The goal of the entire healthcare system is to reduce costs, at the same time be more responsive to customers or your patients. The elderly are actually the heaviest users of the healthcare services, and the percentage of elderly individuals in the population is significantly increasing. Some of your common healthcare facilities, the best known is the General Hospital, which is usually set up to handle care of patients who experience many kinds of diseases and injury. It is typically an emergency department that deals with the immediate threats to health and the capacity to provide emergency medical services. Your general hospital is usually the major healthcare facility in a region. There are types of specialized hospitals, including your trauma centers, your children's hospitals, your senior hospitals, your hospitals for dealing with specific medical needs, such as psychiatric, pulmonary, and orthopedic procedures. In an IDS, an integrated delivery system, inpatient, hospital, and physician services are combined under one entity. This will provide and bill for both hospital and all of the physician services, either through the entity itself or through contractual associations. What is an acute care facility, Kelsey?
A hospital.
Yes, a hospital. It is where most of the people go pretty much year-round, 24/7, right?
Yep.
All right.
Like facility offering inpatient overnight
Yep.
care.
Okay, critical access hospitals. What is a critical access hospital? Anita?
Okay, you could, cost reimbursement from
The
Flexible.
Critical Access Hospital actually was created under the Critical Access Hospital program in 1997. It's a Federal Balanced Budget Act as a safety net to guarantee that Medicare beneficiaries access to healthcare services in rural areas. It was also designed to allow more flexible staffing options that are required by the community, simplify billing methods, and create incentives to develop local integrated health delivery systems that will include the acute, primary, emergency, and long-term care. Ambulatory surgery centers. Ambulatory surgery centers. These are also known as ASCs. They must have at least one dedicated operating room and the equipment needed to perform surgery safely and to ensure quality patient care. Your patients who elect to have surgery in an ASC will arrive on that day of procedure, undergo the procedure in a specially equipped operating room, and recover under the care of the nursing staff, all without a hospital admission. Some of your other types of healthcare facilities would be subacute care facility. What is a subacute care facility, Kelsey?
Inpatient program designed for individuals who have experienced an acute event as a result of an illness, injury, or exacerbation.
Yes.
Disease.
What is a skilled nursing facility, Anitha?
It's an skilled nursing facility is an institution or distinct part of institution that is licensed or approved under state or local law and primarily engaged in providing skilled nursing care and related services.
Yes.
Okay, extended care facility or nursing care facility approved by Joint Commission.
All right, intermediate care facility. Kelsey, what is that?
Designed for individuals with chronic conditions who are not able to live independently, but who don't need constant intensive care.
Yes. All right, and what is a hospice, Anitha?
It's a facility or service that provides care for terminally ill patients and support to their families, either directly or on a consulting basis with the patient's physician.
Yes. And what about home health agencies, Kelsey?
They provide a wide range of healthcare services that can be given in the patient's home.
Yep. All right. Legal and regulatory environment on page 409. The U.S. Department of Health and Human Services enforces those standards by periodically conducting surveys of these facilities. Your Medicare pays for services that are provided by hospitals that voluntarily seek and are approved for certification by the Centers for Medicare and Medicaid Services. CMS contracts with HHS to evaluate compliance with the federal hospital regulations by periodically conducting surveys of these agencies. Over on page 410, the EMTALA. This is an Emergency Medical Treatment and Labor Act. It was enacted by Congress as part of the Consolidated Omnibus Reconciliation Act of 1985, also known as COBRA. It applies to all medical hospitals, and hospitals cannot turn away patients who come to their emergency departments for treatment. Accreditation is a voluntary process. Its private or public agency evaluates and recognizes an institution as fulfilling those applicable standards. Your accrediting organizations, the Joint Commission, the National Committee for Quality Assurance, the Accreditation Association for Ambulatory Health Care, and Utilization Review Accreditation Commission. What are professional standards over on page 411? Give me an example of a professional standard, Kelsey.
Joint.
I don't know what the right answer is.
Well, just an example would be to ask hospitals to define a process for supervision of residents by a licensed independent practitioner with appropriate clinical privileges, or to provide medical staff with written descriptions of their role, their responsibilities, and their patient care activities. We just want to have standards. So what would we consider standards? That's what we're looking for. Okay? Governance. Governance, in its widest sense, refers to how an organization is run. Confidentiality and privacy this is where you as the hospital staff or health insurance professional must be aware of, understand, and abide by HIPAA's privacy standards. Some of the HIPAA topics are listed on page 411 of your textbook. Covered entities under HIPAA. Under HIPAA, a covered entity is any health plan, healthcare clearinghouse, or healthcare provider who transmits health information in electronic form in connection with a transaction. Under the privacy rules, some practices are permissible. Fair treatment of patients. The basic principles of medical ethics include showing respect for patient autonomy, not inflicting harm on patients, contributing to the welfare of patients, and promoting justice for and fair treatment of patients. Some common hospital payers on page 413. Medicare is one of the biggest carriers. Your Medicare hospital claims are processed by non-government organizations or agencies that actually contract to serve as the fiscal agent between providers and the federal government. Medicaid, each state determines the method of payment for inpatient services. TRICARE patients must use military treatment facilities or ask for NAS if no facilities are available. What is NAS? What do you think NAS is, Kelsey?
Non-availability statement?
Yes, good job. Chapt VA uses the same DRG-based PPS as that used by TRICARE. Typically, they pay the allowed amount minus the beneficiary cost share. Then we have Blue Cross and Blue Shield on page 416. This is another big payer. They offer inpatient hospital reimbursement. It will differ region from region, and it depends on benefit coverage outlined in the contract. Your private insurers, they negotiate contracts with the facilities for the hospital inpatient payment methods, and many will use a DRG system. Your UBO4 is also known as the CMS 1450. It is a paper claim form that is used by institutional providers. The electronic version of the UBO4 form is the 837I version 5010 claim. And the National Uniform Billing Committee is responsible for the design and printing of the UBO4. Your UBO4 data specifications are very similar to that in the CMS 1500 form. There are data elements that are assigned by designated spaces, and each one has a unique number. The 837I conforms to data elements on the paper UBO4. There is an upgrade to 5010 accommodating the ICD-10 codes. The transaction set, overall, the data stream of an 837I file, every section contains a data segment. And then your claims will be submitted in batches. The structure and content over on page 420 is very similar to a physician's office or medical record. It still contains all of the demographic, the health care that they received, observations, medical or surgical interventions, treatment outcomes, information that the patient provides, results of exams and lab tests, radiology reports, diagnoses, treatment plans. Standards in the hospital EMR. The EMR system will incorporate patients' clinical information, clinical decision support databases, orders management, workflow management, security features, electronic prescription tool, and patients' financial records. Some EMR factors to consider will be the ease of use, system interoperability, standardization, workflow capacities, sales team of the vendor, and vendor services. Some of your EMR benefits. It will provide faster accessibility to the records. So as we see in the outpatient side, we see similar advantages in the hospital side. Your inpatient and hospital and facility coding on page 422. ICD-9-CM Volume 3 is used for your coding and reporting inpatient hospital procedures. Your inpatient hospital claims require reporting the principal procedure if there's a significant procedure occurring during hospitalization. Volume 3 contains the alphabetic index and the tabular list that you see being used for hospital claims. The code sets that are used will be the ICD-10 PCS. This is used reporting inpatient procedures only. Your ICD-10 CM is used in all of your health treatment facilities, both outpatient and inpatient, for coding diagnoses. I'm not going to go into ICD-10 because we are going to review it when we get into the Buck book. So I'm not going to Let's talk about the hospital billing process. The hospital billing process over on
Page 430.
Yes, thank you. The hospital billing process on page 430 begins with the patient registration. So you're going to see some similarities here as well. The same, very similar with outpatient. It begins with the patient registration. This must be accomplished in person, by phone, or via the internet. Pre-authorization and pre-certification necessary for most inpatient hospital admissions. Patients should be informed of their rights and responsibilities. Informed consent, process by which a fully informed patient can participate in choices about his or her health care. It includes discussion of the nature of the decision of the procedure, reasonable alternatives to be proposed intervention, relevant risks, benefits, and uncertainties related to each alternative, assessment of patient understanding, acceptance of the intervention by the patient. The difference here is that POA and hospital charges. So POA is present on admission, and then hospital charges will have facility charges and ancillary charges. The charge description master is used to determine those charges. Your electronic claim submission on page 433. Again, this is very similar to outpatient, where it is the most efficient and effective means of processing the claims. It allows your providers to submit claims to a central location. It avoids the sorting and keying process, allows providers to check their claims, provides an audit trail of claims that have failed preliminary edits, and it allows for information about problems to be received within hours. Your health information management systems. On page 434, this is coding and abstracting all of the patient charts and releasing them for billing. Again, very similar to outpatient process. It improves coding accuracy. You have an ERA management. Your software components handle the patient registration, eligibility verification, claims management, accounts receivable, collections. So you'll see at the top of page 434 in the right-hand column, it gives you an example of the hospital billing flow chart. You'll notice it is pretty similar in an outpatient setting. There's not much variation at all. The HIPAA and hospital connection. HIPAA requires providers to submit initial Medicare claims electronically. There are exception categories. Unless a provider fits one of the exception categories, your paper claims submitted to Medicare will not be paid. Billing compliance. Billing compliance begins with the gathering of the complete and accurate information during the admission and the registration process. So a good program provides instruction relating to compliance standards to all personnel that are involved in the full circle of that process of claim development. What are the career opportunities in hospital billing? On page 436. Hospitals, physician offices, nursing care facilities, outpatient care centers, home health care services, insurance firms, and public health departments. Your medical records and your health information technicians actually held more than 172,000 jobs in 2008, and 37% of those jobs were in the hospitals. training, other qualifications, and advancement. You'll see that there are associate degrees with areas of study in general education, medical terminology, anatomy and physiology, legal aspects of health information, coding and abstraction of data, statistics, database management, quality improvement methods, and computer science. All right. So for certification, most of your employers prefer to hire a registered health information technician. You must graduate from a 2-year associate degree program that is usually accredited by Commission on Accreditation of Allied Health Education Programs. You must pass a written exam offered by the American Health Information Management Association, or also known as AHIMA. You'll notice that for the job outlook, this is faster than average growth. Most of your new jobs are in physician offices, especially in large group practices. There's rapid growth in nursing care facilities, home health care services, and outpatient care centers. You'll also see that you'll have additional job openings to replace those leaving the profession. Any questions here, ladies?
So we don't really have a good chance of getting hired in a hospital, right?
Not right off. I would say the best thing to do is to start by volunteering. Start volunteering, get yourself in the door, medical records.
But with the smaller groups, that shouldn't be a problem, right?
Pretty good, right?
Okay.
Yeah. I would say never, okay?
Yeah.
Because I have several students right now who are actually have job opportunities lined up for them. And I have one in particular who applied for this job, and she's like, oh, I'm not going to get it. I'm not going to get it. You know, I'm brand new. What are they going to want me for? Well, guess what? She is one of 3 candidates, and the reason that they want someone like her is because they can train her and mold her the way they want her to be.
Yeah. And is she volunteering in a hospital right now?
No, she's not.
Oh, so how did she do that?
She just applied for the job.
Oh.
So don't negate it, okay? Don't look at it and say, well, I can't do that. My thought process is that you have nothing to lose by interviewing and applying for anything and everything within the billing and coding world.
Yeah.
You honestly have nothing to lose. If anything, you have everything to gain, because every application, every interview gets you that step closer, that next step closer. And you learn so much from each interview, from each opportunity that you put yourself in, that you're only growing more as a person and an individual by putting yourself in those positions to get to where you want to go. Does that make sense?
Yeah.
Does that help?
Is there a big difference in salary between a hospital and a smaller, like, physician's office?
There can be. I would say that if you can get in with those physician practices that have the multi-physician practices, that's probably a good place to start. So if you can try and volunteer there somewhere, or get a job as, you know, the front desk person, and then work your way up.
Okay.
You know, because you have a better opportunity of being there and being available for when a job opening comes up. In the single doctor, single staff practice, yes, you're going to see a a much smaller salary type because it is a single practice. It is a single practitioner.
Mm-hmm.
So most practitioners start anywhere between, I'd say, 12 and 18 an hour. So lower, industry standards, but still a way to get yourself in the door. Get some experience under your belt. So from here out, for the next 15 to 20 weeks, what I would challenge each and every one of you to start thinking about as we move through the Buck Book and the different chapters, look in your local community. Where can you travel to maybe job shadow or volunteer some time anywhere in the practice, even if it's a couple hours a day or a week. I'm going to school for medical billing and coding. You would be so surprised at who you actually know that you could be asking to give you a couple hours a week somewhere. And go to the hospital. I don't know what's up there in Gardner, right?
Yeah, I don't know. But I'm always
Okay.
in the Brunswick Topsom area anyway.
Okay. So go there.
Yeah.
There's got to be Parkview, right?
Yeah, there's Martin's Point too.
Bitpost, Martin's Point.
Yeah.
Okay. Start now to try and find a place that you can just go and ask and see if opportunities open up. Okay?
Yep.
All right. Any questions?
No.
Anita?
No.
Am I pronouncing your name correctly?
Yeah.
Okay. So, what is your takeaway from tonight, Kelsey?
Well, I feel like those chapters basically went over the book that we already did. The chapters ahead.
Okay. Which was what book?
No, this book. I mean the chapters we've already done.
Oh, okay. So how do you feel about the whole book overall?
Definitely glad we don't have to memorize it, but it is nice to know, all the ins and outs and everything there is to know about health insurance.
Yeah. And it honestly is a good resource for you. So it wouldn't hurt to have it handy. Anita, what is your takeaway from tonight?
Yeah, I did understand the whole whole concept of billing, like how it goes, and if in interview point of do we have to know very particular, like some of the terms we may I'm don't remember.
You should know what a copay is, what a coinsurance is, what a deductible is.
Mm-hmm.
Okay. Who your insurance carriers are: Anthem, Cigna, United Healthcare, Harvard Pilgrim, Medicare, your Advantage plans, TRICARE, Chapt VA. In an interview, they might ask you, what is your billing experience? If you can think about billing like keeping track of your checkbook, okay? Mm-hmm. You get bills that come in the mail. You have to pay those bills because you're paying for services rendered, whether it is your electricity or your car being serviced or going to the doctor's office and paying your copay. Think about billing for the insurance world as just a bigger project than keeping track of your checkbook. Okay? So you go to the grocery store. You pick up all of your groceries. You put them in a cart. You go to the checkout and you pay by cash, check, or credit card. Well, the same thing in the billing world. You present to the doctor for the encounter. So you just went to the grocery store for groceries. All right? So then you tell the doctor what's wrong with you. And the doctor provides a service. He provides an evaluation and management or an exam. He then may, let's choose a chiropractic office because I work for chiropractic office. And he then does a chiropractic manipulation. So he performed 2 services and he charged you for those services and you check out. So in the grocery store, we've picked up a cart full of groceries. Those would be like our services, our procedures. And we go to the checkout counter. The doctor, we paid them a copay or a coinsurance depending on what we had for our services and what our plan covers. In the grocery store, we get to the checkout. The cashier checks them all through. They get on a slip. Okay, so we have an encounter form or a fee slip at checkout. We pay our bill. Well, in the grocery store, it might be that if you're putting it on a credit card, we can't go over $200 because that's all we have left on our credit card, okay? In the doctor's office, it's going to be either $25 copay or, $15.30, depending on the coinsurance. So if you can think about that, putting that information down on a CMS 1500 form, okay, name, address, phone number, date of birth, social security number, insurance information. Who's the doctor? What's the date of service? What are the procedures? What are the diagnosis codes? Who's billing it? Who's the referring provider if we had one? Who's the rendering provider? That's how simple billing is. I know it took 18 chapters to explain billing to you, but it's all that background stuff that you need to know to do the billing. So like going to the grocery store, you need to know what you need at the store. So you put a list together. Is that a good analogy?
Yeah.
Does that help?
Yeah.
Yes.
Okay. So really what this book is for you is a resource. And it helps to outline, the fact that we need HIPAA, that we have EMRs, that we have a legal and ethical side, that we, what is the origin of health insurance? Well, who even knew, right? Who knew health insurance? What was it? What are the tools of the trade? Okay, so here are the tools of the trade. This is what we talked about in Chapter 2. And remember, when you're looking for jobs, think about those different ways that they're going to put those jobs out there. It might not be a billing specialist. It might be a front office certification. Types and sources of health insurance. Okay, so knowing the different types. Claim submission methods, paper or electronic. Traditional fee-for-service and private plans. So who are they? Unraveling the mysteries of managed care. Managed care is HMO. HMOs, the gatekeepers. Okay. What's Medicare? What's Medicaid? What are Medicare's challenges? In the outpatient world, it's pretty simple. In the outpatient world, it is really just knowing what they pay for depending on the specialty you're working in. military carriers, what is their coverage? Your workers' comp and your disability, what do they cover? How is it covered? So with workers' comp, you make sure that you have an M1 form for the first visit. Personal injury cases, you want an accident report. You want to know who's at fault, not who's at fault, but who's the insurance carrier, who's the health insurance. And then we need to know what type of diagnostic codes we're going to use, what type of procedure codes we're going to use. Are we going to use an E&M every time? Are we going to have only a certain number of codes? In chiropractic, we have only 35 procedure codes that we use. We can use any list of diagnoses. We're limited to certain primary diagnoses, but the second, third, and fourth diagnoses and so on can be a whole host of other types of diagnoses. And then
So in chiropractic, do they use CPT? Like
they do. In outpatient, they use all CPTs.
Yeah.
Okay. Then in Unit 4, we went through the claims process. We went through the HIPAA requirements, the laws that affect credit and collection. We talked about in Chapter 15 the keys to successful claims management. I can tell you from my experience, and this is tried and true every single time, the registration process or the new patient intake process is probably the most critical process you will perform. And the reason being is that is when you do all of your data gathering to get the information that you need to bill those claims clean and correct the first time. And we talked about what that information is that you need. It is all the demographic information, what type of insurance, who is the subscriber, do they need authorization or pre-certification, what are they coming in for, what is their phone number, and copying those insurance cards and getting a copy of their driver's license, because we want to prove who they are, that they are who they say they are. We want to make sure that when we put that information in the computer, we are spell checking it. We are putting it in the computer the exact same way it is on the insurance card. Believe it or not, if you have an insurance card that says Mary B. Smith, you better be putting her information in the computer as Mary B. Smith, because the claim, the payer, will deny if you forget the middle initial. If you add a period where you shouldn't have one. If you put a hyphen or a dash where you shouldn't have one. If you forget an ID number, character. All of these reasons will deny a claim. So claim errors. What are the things that would be claim errors? Those items I just mentioned to you. So that intake process is one of the most critical steps you will make in data gathering. The reimbursement procedures we talked about in Chapter 17, how to get paid. So when we talk about why the patient came in, does the doctor's documentation support the diagnosis codes and the CPT codes that he put on the form or in the computer? Do we know absolutely for sure that what he put in there is true and correct? And then Chapter 18, we talked about hospital billing, and I hope that you saw how similar it is to outpatient billing. It's just on a larger scale. It's all done very similarly, just on a larger scale.
So in outpatient, do we use like ICD-9 procedure codes, like diagnosis codes, and here with ICD-10 procedure codes, right? In outpatient. No, inpatient.
Inpatient and outpatient, you use ICD-9 codes currently. In the ICD-9 book, you will use volume 3 primarily for the inpatient, but you can also use volume 1 and 2. In the outpatient, you only use volume 1 and 2.
Volume 1 and 2 and CPT?
Yes, and CPT. CPT is both hospital and outpatient. Don't get those two confused. Your procedure codes are your procedure codes are your procedure codes. You will use those for inpatient and outpatient. Your diagnostic codes, you have 3 volumes, and we will talk about that in the next class. So for your next class, you are going to need your buck book. You will need your textbook and your workbook.
What are the lists?
You need the buck book, the buck textbook, and the buck workbook. And I want you to bring your ICD-9 book. That's all you need next week.
So I did understand 12th chapter, like theoretically. So if we means like if we do practice on ICD-9 book, it might be easy, right? Just I did understand means like okay, how to figure out the diagnosis, then check in the index and
Yeah,
then again.
We'll be working with those, but we won't be looking up codes next week.
Oh, okay.
It will get into it probably closer to like week 8 and 9. But I want you to bring your ICD-9 book for next class with your buck book and your buck workbook. So I want you to read chapter 1 in your buck book. I want you to do all of the in-chapter exercises, the theory and practical at the end of chapter 1, and chapter 1 in the workbook. And then go on Evolve and finish the Evolve exercises for this book that.
And are we doing any of the what did you learns in these chapters?
Even numbers.
Okay.
For 16 through 18. Okay, any last minute questions? I know we're a little early, but I think that's good.
I don't
So
have
next
any.
week is off and
Yes, next week is off, so we won't be back here until Wednesday the 29th. Okay? All right, ladies. Well, thank you very much for your time tonight.
Thank you.
thank you.
I hope you have a good week.
You too.
Thank you.
All right, take care.
Did you do